Well, hello. So I'm going to be giving a lecture on back to the basics for MSA 101. And I'm Siegfried Hirczy. I'm one of the movement disorder clinicians at the University of Texas Southwestern, one of the MSA Centers of Excellence. I'm also an assistant professor there. Okay, but I'm very excited to give this talk. And so what is multiple systems atrophy? So it's a rare, progressive neurodegenerative disorder, and it affects multiple systems. And so it affects movement, balance and coordination, and autonomic nerve functions. And automatic nerve functions means things that you don't have to think about that your nervous system controls, like moving your bowels and bladder and controlling your blood pressures. And we think that this disorder is related to the buildup of a protein called alpha-synuclein in brain and in those nerves throughout your body. And so what types of MSA are there? So there are two types. There's MSA-P for Parkinsonian, and there's MSA-C for cerebellar. They share many features, but one of things is more prominent in one versus the other. So in the P type, the Parkinsonian type, individuals are more affected by slowness, stiffness, and tremors, and these fancy terms that are popular are bradykinesia and rigidity and things like that. And they look like people with Parkinson's, and they can be hard to distinguish from Parkinson's initially. And then in the C or cerebellar variant, these individuals are affected by ataxia. And that just means difficulty with coordination. And so individuals will suffer from clumsiness. They'll struggle with writing and typing and fine motor activities. They'll have imbalance and walking difficulties. And so they'll have to take more cautious steps or may need a cane or a walker. And other things are affected too, like speech, where people will start sounding slurred, and various things that require coordination can change. So how common is MSA? And so it is a very rare condition. Some estimates put it around 3 to 7 per 100,000 people at a given time have MSA. It's can vary roughly, maybe 100 times less common than Parkinson's disease, which is already a not very common disorder. And most people are diagnosed between the age of 40 and 60. And it is not considered to be a familial or genetic disorder. So it is very odd to hear someone saying, my mother or my father, or many people in the family who have a similar condition. It's usually actually indicative of another kind of disorder. Well, so how does MSA actually affect individuals? And so we like to put things into buckets. And the main bucket is bucket one, movement symptoms. And again, they go into the Parkinsonian symptoms, the Parkinsonism, which we again talk about slowness, stiffness, tremors. And then we have another set of movement symptoms, which are those ataxic symptoms or cerebellar symptoms that we talk about clumsiness, imbalance, slurring of speech. And these can overlap and look similar at times, but they have a little bit of a distinct profile. And they all come to make it more challenging to get the body to do what the brain wants and to continue to be independent and mobile becomes more challenging because of these various symptoms. And then the second big set are these autonomic symptoms. And people with MSA can have cardiovascular symptoms, urinary, gastrointestinal. And so one of the common things that people with MSA note is dizziness on standing, and dizziness the longer they're up. This is the orthostatic hypotension, which just means when up, blood likes to go down because of gravity, and there's less blood perfusing or going to the brain to support it. And so people will feel lightheaded or faint. It's one of those words that is used. And it usually gets worse the longer someone is up, the longer they're trying to do things. And this can affect their balance and also can affect their ambulation. Another thing is temperature regulation. So people can feel cold and clammy and have discoloration of their hands. Urinary issues usually manifest in frequency, or they can have incontinence or retention. And that is a big issue and needs something to work on to prevent infections. And then gastrointestinal issues, including constipation or early satiety, where people don't eat as much as they used to or feel full very easily. These are also very common in MSA. And so how is MSA diagnosed? So MSA is diagnosed clinically, and it's based on the presence or absence of many features. Kind of have a checklist that we go through. There's no single test that confirms MSA, and that makes it challenging at times. Data drives our diagnosis. And so what data do clinicians use? Well, a history, physical exam, response to medications like carbidopa-levodopa or Sinemet, the medication used in Parkinson's, because the response is not as strong. MRIs to look for certain abnormalities that we can see in certain regions of the brain. Radio tracer scans, which are another kind of scan where we can look and see if certain areas are more affected from a functional perspective, looking if the neurons are there. And autonomic testing, where we look at vitals and how they respond to different kinds of pressures. We can look at bladder function. And so these are ways of understanding those symptoms and understanding objectively what are causing those symptoms. And then more novelly and new are tests for the alpha-synuclein that was mentioned earlier, which is this protein that we think is related to the disorder, whether it's driving it or whether it's just a component. It remains to be seen. And then very critically, evaluating for other disorders or confounding factors that may mimic MSA. There are several other disorders that have alpha-synuclein, and Parkinson's is one, but there are others. And sometimes they can look very similar because something else is going on that kind of gives it a little bit of an MSA flavor. And then sometimes there are genetic forms that travel in families that can look like MSA. Usually they don't progress quite as fast, and there's genetic testing that can be obtained for those. So how does MSA change over time? So the disorder starts with subtle changes to any of the systems that I talked about. So it could be subtle autonomic dysfunction, causing dizziness when standing or in hot conditions. It could be clumsiness when writing, typing, and walking, was kind of imbalanced. It's not related to dizziness, just it's feeling a little bit drunk over the course of the day. And then slowness and decreased movement, where things that used to be easy are harder to do, and more it gets done, the kind of harder it gets. People just move slower and don't keep up with their spouses or family members or friends like they used to. And unfortunately, this is a progressive disorder. And so these subtle changes, they become more and more notable over time and become more bothersome. And they become bothersome at a rate that is almost higher. Well, it's faster than Parkinson's changes. And in the later stages, MSA becomes debilitating, profoundly limiting mobility and independence. And requiring people to have assistance from others and from devices. So how do we treat and manage this disorder? And so we have many treatments. They can increase function and reduce symptoms. The key goals of our treatments are to increase mobility, reduce falls, and to reduce risks of infections and other complications. But unfortunately, at this time, we don't have a cure for MSA, and we don't have anything that clearly slows down progression. Care is best provided by an integrated team of clinicians and other individuals. And it's useful to have a neurologist, a rehab physician, and various therapists, a urologist, sleep specialist, a palliative care doctor, social workers, and other support can also be very important. Nutritionists. So it's important to be taken care of by a good network of clinicians. And looking ahead is also very important. So for individuals with MSA, planning is critical. It can help prevent complications, make sure that there's support available when needed for both patients and for caregivers. And it allows legal and medical decisions to align with personal goals and wishes. While we look forward to a time where it doesn't continue to progress, at least we know that the future is going to need more things. And so we can plan for that future in advance. And a big topic is, well, what is going on in research? And so for MSA, the key areas are improving diagnosis to make it earlier and more definitive, trying to simplify the checklists so that we can find out if someone has MSA early and hopefully to intervene early, because we feel that if we are able to intervene at the beginning, we may be able to do things that are more impactful, that slow the disease more or potentially cure it in an earlier stage where we have more function. And so that's the second big area, treatments to address symptoms and change the course of the disease. And there are many clinical trials in this space, eagerly await a successful one. Things to know, research is completely optional. And so there are risks and there are benefits potentially, but there's no guarantee of efficacy in a clinical trial. And it is not guaranteed that they are safe either. There are studies that are done to evaluate for safety, but whenever we are trying a novel drug, there are risks. And very importantly and critically, interest in research drives research and supports further development. So even when something doesn't end up working, that doesn't mean that nothing came from it. Valuable insights that can come from that. They may be applied to the individual or to the disease as a whole, or knowledge, general knowledge. And clinicaltrials.gov is a very useful resource where individuals with MSA can look and see if there's a trial that might interest them. And so in closing, there are lots of resources available for people with MSA and people who want to support individuals with MSA. Resources are available through Mission MSA. There are local support communities, and there are actually many other patient advocacy groups for similar disorders where the symptoms are somewhat similar, and you can gather at least some of the same information, the information that can still be utilized because many of the interventions are quite similar at this. And so it's the 101 talk on MSA, and I hope that was useful.